So we are waiting for our president, Dr. G.S. Narang sir, to join. Once he joins, then we'll start, ma'am. Done. Okay, he has joined. Good afternoon, sir, and welcome. Our NRP presentation.
Hi, sir.
Good afternoon, sir.
Sir, you are muted. ਤੁਸੀਂ mute ਹੈ ਕਿਉਂ sir? ਤੁਸੀਂ unmute ਕਰੋ। Sir, unmute ਕਰੋ। ਸੁਣ ਨਹੀਂ ਰਿਹਾ।
करता ये तो अनम्यूट ही
ठीक
Hi,
है।
sir. कैसे हैं
आइए
आप?
बात
हाँ
सर गुड
जी, हाँ जी,
आफ्टरनून
आ रही है सर।
डॉक्टर शोभना गुड आफ्टरनून
सर शुरू
Good
करिए।
afternoon, sir. Good afternoon.
शुरू करिए। Shall we start, sir?
हाँ जी श्योर
Okay. Good afternoon, everyone. On behalf of Satluj Academy of Pediatrics, State IIP Chapter of Punjab, we welcome everyone on the nationwide NRP motivation to mass training each and every individual so that we reduce neonatal mortality rate in India. In this wave, we have planned a very interesting webinar from a very lead neonatologist and senior neonatologist, Dr. Shobna Rajendran, on NRP latest guidelines for term and preterm. For this session, we have excellent chairperson, Dr. Shashikant Dhir sir, professor and HOD GGS MCH Faridkot. And now I request our president to formally start the meet and welcome our speaker and chairperson, sir. Over to you, sir. Sir? I think there is some issue with him. He said that he is busy in class. So I request Dr. Shashi sir to kindly introduce ma'am.
Hello, good afternoon, everyone. Hi, Dr. Shobna. Thank you, Dr. Seema and Dr. Narak. So it's my proud privilege to introduce the speaker of the day, Dr. Shobna Rajendran. She has done DNB and in neonatology. And as of now, she is working as a lead consultant in Rainbow Children Hospital, Chennai. She is very, very enthusiastic teacher of NRP and she is a national faculty in NRP program. She is also a national board medalist in DNB program. And it's also very interesting to see that she has been instrumental in setting up 2 human milk bank, which are the nectar for any neonate. And in addition to that, she is very good in research, also has got many indexed publications in neonatology. So as we all know that NRP is the key domain to decrease the neonatal mortality rate. And it is this year that new guidelines have come. It will be very interesting to see what Dr. Shobna, a master in this field, has to delegate. So over to you, Dr. Shobna.
Thank you. Thank you.
Thank you, sir. Thank you, Punjab NNF, IAP for all the kind invitation and having me speak on a chapter that is very close to my heart. And without taking much time, I'm going to be blending both 25 and 26. So as you know that the NRP 9th edition was released in 25 last year. And they had circulated that it will get incorporated by the 1st of June. Now, the Indian NRP has incorporated some of its changes into the Indian version and has released a manual. The booklet is yet to get incorporated. So we will just go through the salient differences that we might be experiencing between the previous manual of Indian NRP as well as the US one. So just getting started. So the key note that the AHA had released is all providers to transit by June 1st, 2026 to the new algorithm. And also there is an NRP essential chapter, which is 1 to 4, which is equivalent to the basic NRP in India. And the NRP advanced, which is between the 1 to 11th chapter, which is the advanced NRP that we do here. Now, this is the algorithm that has undergone a bit of the change. Probably we'll go through sector by sector. What is the change in the algorithm terminology, how it has changed between ventilation and cord clamping styles. So if you take a look at this algorithm in a glance, the first thing that we're going to talk about is the birth and the delayed cord management or the cord management. Now, the new NRP book has these 16 chapters. The earlier one was with 14 chapters, 15 and 16 are added. They have the core chapters which are between 1 to 11, and the supplemental lessons which are between 12 to 16, of which the 15, the resuscitation and stabilization of a newborn with congenital heart disease, and resuscitation in a neonatal intensive care are new additions. The 1 to 4 chapter actually works on the basic NRP, and the 1 to 11 chapter works on the advanced NRP. Now, moving on, neonatal resuscitation. It is so important because though in every baby who is born at term even, 85% of them will require no resuscitation. 10% will require initial steps, just like keeping them warm, drying, and stimulating, they start transiting. 5% of them will require a positive pressure ventilation, and 1% will require an intubation. And chest compressions and drug is usually for 1 to 3 per 1,000 births. So we can see that 15% of the babies will require some sort of a
शगुन इसको
support.
अपने पास
So
बिठाओ.
it's very essential that all of us are quite streamlined with NRP so that every birth will have a good transit, and we are all working towards the single digit NMR, in which the NRP would be very pivotal. Now we'll go back into the algorithm. So the algorithm, the first part, the antenatal counseling, team briefing, and equipment checklist has seen no change. The initial 4 vital questions have seen no change. It's the same expected gestational age, what is the fluid, and additional risk factors, and definitely an umbilical cord management is there. But if you see the algorithm, the birth is given a separate box and the initial cord management plan is given a separate box. So the cord management has become a different entity which has to be discussed beforehand and have a clear plan on the cord management. So what is the supplies that they have told in the, what are the equipments? The equipments have largely been the same, except for a huge emphasis on size 2 ET, LMA, as well as the what's the other one? Intraosseous needle. A little more emphasis has been come onto it, so that all the equipments are similar, except for a big emphasis on LMA has to be available. Along with that, a size 2 ET tube for younger, smaller babies, and an intraosseous. For the very preterm, it's all the same. There is a plastic wrap need for the less than 32 weeks, a thermal mattress, 00 laryngoscope is optional, a 2-size endotracheal is optional, an incubator to maintain infant temperature. Now, in the key areas of the algorithm, we're going to talk about the birth, cord management, skin to skin contact, and airway clearance. Now, birth and cord management, the above two are given in 2 different boxes, and the emphasis is on cord management is given utmost importance. Skin to skin contact is also in all breathing term babies with good tone. Skin to skin contact has to be given as an immediate action. Earlier, it was spoken largely as a warmth, but here we have as a skin to skin contact to be given as an immediate word. And also in the initial time itself, the suctioning, which is suctioning word, is replaced with clear airway. Even in babies who have not cried or breathed normally, they don't use emphasis for immediate suctioning. They say clear airway, and only if required, suctioning to be done. So the routine suction is removed. Now, coming on to this, as you see in the algorithm, the skin to skin contact as well as the suction word is removed. It goes into a stimulate and clear airway if needed. Now, terminology change. Positive pressure ventilation is changed to assisted ventilation or ventilation. So we don't speak about PPV. We move into words like assisted ventilation or ventilation. And we have given a big way into laryngeal airway mask. Now, delayed cord clamping. The timing for clamping cord for babies who do not need resuscitation has been increased from 30 to 60 seconds to more than 1 minute. So the ideal time for a well-transiting baby, which is essentially a term baby or more than 35 weeks, who is breathing and who has a good tone, can have their cords clamped after 1 minute, between 1 to 3 minutes. This is backed by research which has seen the benefits of delayed cord clamping, when they are done after 1 minute. Now, there's something called umbilical cord milking, which is also a terminology which is being used. These are for babies needing resuscitation, where delaying for 1 minute may not be possible, but they still want to have the benefit of more placental circulation into the baby. So, this is definitely recommended between babies 35 to 42 weeks. It's definitely contraindicated for babies less than 28 weeks because they think rushing the rushing the blood into the 28 weeker can cause IVH. And there is no recommendation between 28 to 34 weeks. So, talking about umbilical cord milking, this can be done in a safe recommendation between babies who are born between 35 to 42 weeks and who need some resuscitation. Now, terminologies for umbilical cord management. Early cord clamping is less than 60 seconds without initiation of respiratory efforts, and deferred cord clamping, which is delayed, clamp it more than 60 seconds before respiratory support. Now, what is intact cord milking? Intact cord milking is what we are talking as the umbilical cord milking technique, wherein you perform the milking, repeated compressions 2 to 4 times of the cord. So you milk for 2 seconds. That is 1, 2, you milk, pause for 2 seconds. 1, 2, you milk, pause for 2 seconds. And it is for a length of 20 to 30 centimeters from the placental side towards the baby, maintaining the placental connection. Each milking should occur at 10 centimeter per second with a pause of 1 to 2 seconds. So overall, in 2 seconds, you would have milked about 20 centimeters, and then you pause for 2 seconds. Again, you can do it, and it is totally done for about 2 to 4 times, and then we stop it. So this, if you do a practice of around 4 seconds every milking, in about 12 to 16 seconds, you would have finished this. So this is the intact cord milking. Now, the next change comes in target saturation. It is essentially not the change because we are going in for a cord clamping beyond 1 minute. Taking a target saturation at 1 minute will become difficult. So, the target saturations have their onset from 2 minutes. At 2 minutes, we want it between 65 to 70. So, the saturation targets are the same. It is just that we are starting to calculate it from the 2 minutes of birth. So that because the first 1 minute goes off in cord clamping, so we will be able to properly document it only after 2 minutes. So we are looking at the target saturations from 2 minutes onwards. Now comes initial FiO2. So the previous edition had FiO2 like in term babies to go for room air or up to 35 weeks to go for room air, and then you can move into 30%. But here, the newer edition has given a definite liberalization of FiO2 to the smaller babies because they now talk about reaching a saturation of 80% within 5 minutes of birth. So they want the saturation to build up to 80% within 5 minutes of birth. So for this, they continue to say that more than 35 weeks, you start with 21% FiO2. Between 32 to 34 weeks, will be 21 to 30% FiO2. But less than 32 weeks, you can go above 30% FiO2, whatever is required, but to come to a target saturation of 80% by 5 minutes. This will be available, or this can be streamlined only in the presence of pulse oximeter. So it's essential that we connect the pulse oximeter to the baby as soon as possible, and the pulse oximeter indications remain the same. Whenever there is a resuscitation anticipated, prolonged cyanosis we are noticing in the event of us giving supplemental oxygen, and when there is an assisted ventilation required, we need to have a pulse oximeter. It is a mandatory requirement. So overall, the new change in the 2025 NRP is a liberalized FiO2 in the preterms and setting up target saturation of 80% 5 minutes. We are actually aiming at during resuscitation. Now comes to ventilation rates. Now ventilation rate, earlier whenever we are giving assisted PPV, positive pressure ventilation, which is now called ventilation, we were giving it at a rate of 40 to 60 breaths per minute. Now they have changed the range to 30 to 60 breaths a minute, with which they think the minute ventilation will be better with the baby. And also, the amount of ventilation which is going on will be more streamlined, and it also coordinates with the number of breaths we give during CPR, that is during chest compressions. We are giving 90 compressions and 30 breaths. This ventilatory rate of 30 to 60 also would intend that range. So we need not focus on 40 to 60. Somewhere around 30 to 60 is the range that is acceptable. Now, coming into the ventilation, so we just had a brief up about the ventilation. So, whenever after the initial steps, that is all the warmth, drying, stimulation, airway clearance, we still have no breathing or apnea, we go into ventilation. So, the changes that we saw in the ventilation are the rate. So, we are going to be ventilating them at a rate of 30 to 60. We are going to be starting them with an FiO2 of either 21%, 21 to 30, or more than 30, depending upon their gestation age. And this is the change in the ventilation. And target saturation also, we are starting to count at 2 minutes. Now the pressure. The PIP initiation in ventilation has also been increased. So in the event of us using a TP's resuscitator, in less than 32 weeks, earlier it was 20 centimeters. Now it is between 20 to 25 centimeters of water. And more than 32 weeks, it is 25 to 30 centimeters of water. So the pressure that we can use in the initial resuscitation has also been increased so that, and this is backed by research, so we are moving approximately 5 centimeters of PIP higher than usual. This is the range that can be given. Now moving on to the circulation aspects. Now, moving on to the ventilatory corrective steps. So earlier, we are all aware about this mnemonic MR SOPA. So what we used to be doing is initial 15 seconds, we give them the breath, about 10 to 15 breaths, and 10 breaths, and we assess for chest rise. Currently, there is a small change that instead of assessing for chest rise within 15 seconds, you can take 30 seconds to assess for chest rise. And if there is no chest rise after 30 seconds of positive pressure of ventilation, earlier we were supposed to do it in a sequence. That is, you do MR, you reseal the mask, you reposition the airway, and then give chest rise 5 breaths and see if there's a chest rise. Now the sequence is changed. It is up to the resuscitator to decide whether he wants to go in the same sequence or depending to whatever is impending the ventilation to change. For example, if the neck is really flexed, he need not reseal the mask. He can just go and reposition the airway. Or if there is secretions pouring in, instead of doing MR and then going in suctioning, the resuscitator can go for a direct suctioning and then continue with the ventilation. So the MR sequence is only for a mnemonic to remember. The sequence can be decided by the resuscitator. So the sequence is removed currently. Now, LMA is one of the massive change in ventilation. Like currently, we are giving positive pressure ventilation or the ventilation. We were earlier left with 3 choices. One is either use a ambu and a mask, or go for a TP's resuscitator or a flow inflating mask. Currently, we have moved into, in the event of mask being not there, or if the resuscitator is more comfortable with the LMA can come in place, which is usually of size 0 and size 1. And it is no more reserved for failed mask or difficult airway. It can be used like any other airway, because with LMA also they can give surfactant, and LMA role is definitely becoming bigger. So in our equipment checklist, if we are incorporating this, then it is necessary that we also have an LMA availability in the equipment. ET sizes. What are the changes that which is undergone for the ET sizes are? They are recommending a smaller tube size for the babies. Earlier, it was less than 1 kg, more than 1 to 2 kg, 2 to 3 kg, more than 3 kg. Currently, it's become 800 to 800 grams. You choose a 2.5 size ET, or who is essentially between 22 to 25 weeks. between 800 to 1.2 kg. Still, it is 2.5. In the earlier one, it would have changed. So it's still 2.5 between 26 to 28 weeks. And the moment the baby becomes more than 1.2 and within 2.2, you can use a 3 size, which is between 29 to 35 weeks. And more than 2.3 kg, you can use a 3.5 size, and it is more than 34 weeks. It is recommended. So if you see in this picture, which is also from the ninth edition, a 2 size is also to be considered for smaller babies who are essentially less than 800 grams or less than 23 weeks, where we might be able, we may sometimes find it difficult for a 2.5, a 2 size also to be considered. And along with the 000 also to be considered. So ET in a glance, the only changes a 2 millimeter endotracheal tube optional may be considered, and up to 1.2 kg, 2.5 be considered, and beyond that we can move size. So we are suggesting a smaller size even for little bit bigger babies. There is another one, you can see a change in the endotracheal tube insertion. Earlier it was tip to lip, now it is tip to gum. So when you are telling about a nasotracheal length plus one and you're measuring, then whatever number that we have said, say 7 or 8, is measured at the gum, which is in the middle, in the maxilla, and not at the lip. So the number that we are in the depth, so according to this chart, less than 23 weeks, suppose we say it is 5 centimeters, then we are fixing the 5 centimeter at gum site, not at lip site. So that is the change. It is from tip to gum instead of tip to lip. Then the depth of insertion is, I wanted to show you this image, the way they are sticking. So they're first encircling the tube, and the size in the image number E, the length is measured at the maxilla of the gum. So as they have a better insertion site, and when we are fixing here in the very small babies, the movement of the ET is also less, and the length of insertion is also better, and accuracy is also better. Now, in the drugs, there are no changes at all. They are the same 1 in 10,000 dilution. And in the IV route, we are recommending, earlier it was 0.1 to 0.3 ml per kg. It is now a standard of 0.2 ml per kg and 1 ml per kg by ET. But these volumes have also a range recommendation, but you can give any of it. You can just go straight IV as 0.2 and endotracheal as 1. And we also have the IV bolus. The bolus is approximately 10 ml per kg over 10 minutes. And epinephrine administration in IV is the preferred route. In the event of not getting an IV, intraosseous can also be given. In volume expanders, there are no change. It is the normal saline. And in very severe anemia or severe cord rupture or obvious blood loss, then it is RHO PRBC. Again, it is through the intravenous, only if it's not available intraosseous. And it is 10 ml per kg is the volume to be given over 5 to 10 minutes. It can be slower in babies who are less than 32 weeks. We've had a brief overview of what are all the changes. Moving into the final setting in one way, if you want to see the settings in the ventilator for the baby or ventilation in the NRP. Oxygen, we have a definite change. That is, we in less than 32 weeks, more than 30% is recommended. The gas flow, there is no change. It is 10 liters per minute. In the rate, there is a change. 30 to 60 breaths per minute is the change. In PIP is also a change. We are moving in for a range of more than 32 weeks between 25 to 30 centimeters of water. And in less than 32 weeks, it is 20 to 25 centimeters of water. And PEEP is no change. It is 5 centimeters of water. So one, citing the difference between 8th and the 9th edition, deferred cord clamping, it is more than 30 seconds. I'm sorry, more than 60 seconds. Ventilation rate is between 30 to 60 seconds compared to 40 to 60 breaths per minute. Initial FiO2, it is in less than 32 weeks was 21 to 30% earlier. Now it is more than 30%. Initial PEEP in smaller babies was 20 to 25. Now the standard itself is 25, and in bigger babies, you can go up to 30. Saturation table starts at 1 minute. Now it starts at 2 minutes. ETT depth is tip to lip in 8th edition and tip to gum in the 9th edition. Now, this is the NRP manual of India. This manual is released, and this is called the 2026 manual. In the 2026 manual, as with every change that we have, you can see that here the cord clamping is also cord clamping and cord milking has been incorporated into it. And the saturation targets also has been incorporated starting from 2 minutes. And the initial FiO2 is also changed. Only in the ventilation step, they continue to use the terminology and the number of breaths, what they are recommending, continues to be at 40 to 60 breaths per minute. Now we move into some preterm resuscitation. In preterm resuscitation, what is different is the same. It is really not changed between the 8th and the 9th edition or in the Indian version. Obviously, when there is a preterm delivery, there is a need for a skilled personnel, definite availability of radiant warmer, a plastic wrap for babies who are born less than 32 weeks, and a transport incubator to ensure a safe euthermic transport of the baby into the NICU. They also need a CPAP. CPAP is definitely mandatory. A T-piece resuscitator where you can give a PEEP, a blended oxygen, and a pulse oximeter. We want the FiO2 to be blended ideally for the preterm babies. Preterm mask, we have 0 and 00. A laryngoscope blade, 0, 00, and even 000 is available. And definitely endotracheal tube 2.5 and 3 in extreme small babies, even 2. And ECG is also recommended for them. Respiratory care, instead of AMBU, a T-piece resuscitator, delivery room CPAP are ideal for them. In the availability of them, almost 50% of the intubations can be avoided. We also want to have a look at the supplemental lesson which is added in the new NRP, which is in the 9th edition, which has a resuscitation and stabilization of newborn infants with congenital heart disease. In this congenital heart disease, they have cited many varieties. Like this is the tabular column which they have given in different types of congenital heart disease. So,
आपको मेरी सीनियर याद है शोभना मैडम
atrial septum or a D.
तो मैंने एक न्यूबॉर्न का था, मैंने कहा चलो उसको स्पीकर बना देते हैं,
tachyarrhythmias, heart blocks.
पता है मैंने उसका
And
सीडी
for each
मंगवाया,
of them, they have
डॉक्टर शी ने
suggested
मंगवा
what
लिया,
would be their saturation,
उसकी बस 3
low
पब्लिकेशन ही है.
oxygen saturation, and what would be the heart rate that they are looking at, and how would the systemic perfusion, and accordingly to treat. So this is a lot of theory, but they have incorporated
नहीं
this.
नहीं रिसर्च
So
करके
even
actually
in
वो
the
प्राइवेट
event of
हॉस्पिटल
us
में
knowing to going in for a resuscitation where we already have an idea about what is the antenatal finding, we have enough fetal echoes to tell us, yes, this baby is going to be born with a heart disease, then we are mentally prepared. The team is also ready. The additional drugs are also ready. And we know what is the target saturation we should be looking at and what would be the arrhythmias that we can anticipate and act accordingly. There is one more chapter, supplemental lesson, which is a resuscitation in neonatal intensive care unit. So in the intensive care unit, sometimes these babies tend to stay longer and they move into pediatric age. So in this chapter, the unique aspect of resuscitation in a neonatal intensive care unit, common causes of clinical decompensation, basic emergency management of arrhythmias and echo, consideration for cardiopulmonary arrest prevention post-resuscitative care. And the last is an interesting point, when to consider using pediatric resuscitation algorithm and considerations. This is one more change that we are looking at. And for the first time, we have PALS also introduced into the book. So this is the tabular column for which gives you a gist about what the 16 chapters will be telling us. In this, the focus is neonatal resuscitation stabilization of newborn at birth, but in the pediatric also we have the PALS given. And if you see in the post resuscitation temperature management, and for infants and children between 24 hours of age and 18 years who remain comatose, and all these are also having the pediatric PALS also incorporated into some babies, especially in the BPD babies who are around 2 months and who suddenly go in for a resuscitation. That time, they even suggest a rescuer between 30 is to 2 to 2 rescuer of 15 is to 2. So, this is an interesting chapter which, if we read, we might have some new thoughts into resuscitating the newborns who have become older now. So there's also a concept of golden hour management. In this golden hour, where NRP is included, the birth is 0 minute. The resuscitation should have been completed by 10 minutes. Transport is 5 minutes. Lines and IV fluids by 55 minutes, and X-ray by 1 hour. And that is the golden hour breakdown. Now, the take home message that I can give you after this session is, first importance is to make the baby breathe. If the baby has breathed, then go for a delayed cord clamping. And if the baby is a preterm and breathing, go for a delivery room CPAP. Overall, avoid hypothermia in the delivery room and consider meeting target saturations and heart rate, and they should be good. So, thank you so much for this opportunity. And in a gist, this is the changes, the overall changes in the NRP practice. To just sum it up, we have an initial FiO2 where there is a change, ventilation pressure and rate, there is a change, endotracheal tube size and the way we are fixing, there is a change, and umbilical cord management, there is only 1 minute, it's more than 1 minute, and we also are speaking about cord milking for them. Thank you so much. I'll be happy to take up any questions. I know I was given an hour, but I have finished it within about 40 minutes. I am a little early, but I'll be happy to take up the questions.
Thank you so much, ma'am, for an excellent session on all the deep insights of changes in NRP from 8th to 9th edition. One question which I received on my personal text is, can you repeat the changes in the intubation, why we are shifting from lips to gums? That was the question asked by resident.
Okay, so all right. So the lip to gum, why it was done is, they found that whenever there was a lip measurement done, the ET was always higher than at the level of the clavicle, and it was not giving a good ventilation. And whatever the measurement they are doing it didn't correlate when they got into the lip, but it correlated better when they got into the gum, and the tube slipping, the way it fixes the depth of insertion was better with the tip to gum rather than tip to lip. It was almost a change of zero point 0.4 to 0.5 centimeter, but that made a lot of difference.
The
And
ventilation.
also with movement and listening, so they have started to measure at this point. So at this point should be the number that you're calculating, even though you're fixing at the lip, but the number 7 should be at the
Gums.
maxilla.
Okay.
Yes,
Dr.
gum.
Kamaldeep, Dr. Kamaldeep, our EB, SAPA EB from Gurdaspur, she is also has in charge of NICU at Gurdaspur Civil Hospital. Dr. Kamal, you would like to discuss anything? Dr. Kamal? Dr. Kamal? I think maybe some network problem. I will check the chat box. Otherwise, in the meanwhile, any participant they can unmute and open the video and directly ask a question one to one. We have that privilege on this site. I will ask. She actually texted me. I will let me call Dr. Kamal. Then she said I wanted to discuss few things with ma'am. Okay. I have you have 3 to 4 minutes with you.
Yeah,
Yeah.
You're asking me. I have the next 20 minutes here because I was
Okay.
supposed to be talking for an hour. So I finished it early. But overall, the major changes are only in the cord and the cord milking. So the cord milking concept is now getting
You
accepted,
wanted to ask me,
and cord
just on the video.
clamping is
Yeah.
definitely more than
Okay.
1 minute.
The meanwhile, sir, Dr. Narang, sir, anything, any input and the final comments from your side? You couldn't join it. Yeah. Dr. Kamal has joined.
Good evening, madam.
You are muted, ma'am. Dr. Kamal, you are muted. Unmute, please. So now you are still with sir. Dr. Rahul sir is with you, and
He is in Child's Trust. I am in Rainbow.
he is in.
Child's Trust. Child's
Acha,
Trust.
he returned back to child trust.
Yes,
Oh,
yes. And he's also in Cloud9.
in the
Cloud9, Chennai.
Cloud9. Okay, okay. Dr. Kamal, you are still
I
muted.
think she's
You are
having
still
some
muted.
network issue. Oneness.
Good evening, ma'am.
Up.
Hello. Good evening, Dr. Kamal.
It's a very good talk. Many things have been added nowadays.
Thank you.
Actually, but I don't think so ki we can count ki whether it is 30 to 60 because when we give bag and mask ventilation, we used to say ki 1 and 2 and 3 and squeeze. Sorry, and
Yeah, that's for the ventilation. That is CPR.
like that.
Mm. Mm.
So, how can we count like 30 to 60 breaths that we are giving while giving bag and mask?
The earlier the bag and mask was breathe 2 3,
Huh.
breathe 2 3, breathe 2 3, and you were doing a sequence approximately 1 per second. That's when you can reach 60 breaths a minute. And your range that was discussed was 40 to 60. But you're giving a similar ventilation even when the baby goes into a intubation and CPR. Suppose chest compressions we are giving, then we are giving 90 chest compressions and 30 breaths. So in ventilation also, they are not very stringent that they want 40 to 60. They are saying even if it is between 30 to 60, it is okay. We want a good minute ventilation for the baby. So you do not have to hurry on delivering 40 to 60. 30 to 60 is also acceptable. In the event of the child's heart rate not raising up, then definitely we'll be doing the ventilatory corrective steps and we might be increasing the rate or the pressure. But the new NRP's idea on it is just you can liberalize the rate between 30 to 60. But this is one point that is not included in the Indian NRP 2026 manual. So the Indian NRP also has a 26 manual released, which has incorporated some changes of the 9th edition of NRP into
Can I
the
call you, sir,
Indian
for the
26 edition,
final comments?
which is the 4th edition. In that, this 40 to 60 rate continues. They have not
हाँ,
changed
उन्होंने
it into 30
डिस्कशन
to
खत्म
60.
कर दिया वो डिस्कशन
I hope I answered your question. So
Thank
the number of breaths during CPR remains the same. That is 90 compressions and 30 breaths. But only during positive pressure ventilation, it is not stringent 40 to 60 breaths. It can even be 30 to 60 breaths. So in a baby who is mildly asphyxiated and who will trigger up their breathing within few seconds, we need not focus 40 breaths. So even in them, 30 breaths could have worked. So that is the range that they have increased.
Okay. Thank you, ma'am.
Thank you.
Any other questions, comments are welcome from Dr. Pradeep who would like to ask something. Dr. Pradeep, you are muted. You're muted, sir.
Good afternoon, sir.
Sir, you're still muted. So, in case any other resident or any other participant want to ask, they can type in the chat box or directly switch on their camera, unmute themselves, and directly ask question from ma'am. She's with us till 3, I think.
Some other changes, they have become little liberal with oxygen because of the ROP fear, CLD fear. We were restricting the preterms to 30% FiO2. That tag is taken off. So with the more the preterm, you give a higher FiO2. So up to 32 weeks, 32 to 34 weeks, if you're giving between 21 to 30%, less than 32 weeks, please give more than 30% and try to achieve a target saturation of 80% by the 5th minute of life.
By the pulse oximeter.
That is the current status. Yeah.
As I think, I don't think so. Any other more questions and comments? And Dr. Narang sir, have you left? Is here. Let me check. Narang sir, are you still there in the meeting? Okay, I think he was in some web seminar in his own department. So he said, okay, I will join and we'll oscillate. So, okay, thank you so much, ma'am, for accepting our invitation.
Thank you. Thanks a lot.
And
Thank you. It's a very passionate session. I mean, passionate topic for me also. I love to talk about NRP anytime. And thank you for having given the opportunity. And I'm so glad that we had so many listeners who have patiently stayed
we
to
will.
the end. Thank you so
We
much.
will have more listeners to our list because this will go in our YouTube Sapa channel. I will share with you as well the recordings. Please share and subscribe further as well. Thank you so much, ma'am. Thank you.
Thank you.
Thank
Thanks
you.
a lot. Bye-bye. Bye.
Bye
Thank
bye.
you.
Thanks all the respected delegates, participants, senior pediatrician consultant for joining. Thank you, our chairperson, Dr. Shrikant Dhir sir, for sparing his time out of his busy schedule. He is also DM neonatologist in PGI, and I forgot to mention, I think, at that start, and he also joined, but had to leave because of some meeting. So thank you so much, everyone, for joining and making this discussion a wonderful one. And kindly share, subscribe our channel, Sapa. This recording will be available on YouTube as well. Thank you so much, everyone.
Thank you. Thank you so much.